Hello and welcome to Sensei podcast. This is Manos Brilakis discussing with leaders in the field of CTO and complex PCI. Sensei means teacher or master in Japanese. The goal of the Sensei podcast is to help you learn and improve in CTO and complex PCI so that you can become the best that you can be and offer your patients the best possible results. Hello everyone and welcome to Sensei podcast. It is my great pleasure to introduce Dr. Marco Valgimigli, our guest today, who doesn't need much introduction. He is well known to everyone for his pioneering work on multiple fields. He is the deputy chief at the Cardiocentro Ticino Institute in Switzerland. Marco, thank you so much for coming to the podcast today.
Thank you very much, Manos, for having me. I'm really very thrilled to be here and very happy that you are interviewing me today.
Wonderful. So, Marco, you've done a phenomenal work over many, many years. But going back to the beginning, how did it start for you? Did you always want to become a cardiologist? Did you always want to do research? You want to do clinical work? How did this all begin for you?
Well, thank you for asking this. In fact, the answer is no. It was unclear to me that I wanted to become a cardiologist. I, in fact, applied in Italy. My residency was in internal medicine with a branch into emergency medicine. That's what I wanted to become. And then, unfortunately, all of a sudden, because of these university logics that you may not understand from a US perspective, but from Italy perspective, it actually was the case. I was ending up doing research in really the lab, not the catheterization laboratory, but really basic science. And in fact, not in cardiology, not in urgencies, but in internal medicine. So after 2 years of depression, I decided to restart from scratch. And in fact, I took myself out from my university, which was Bologna back then, and to restart back from scratch into another university, which was one of the few in Italy, which was allowing me to start from scratch another residency, which was cardiology. At that moment, it was unclear to me that I wanted to become an interventional cardiologist, so I really applied to become a general cardiologist. Then, all of a sudden, when I started my specific training in the cath lab, then it was really love by first sight. I was completely falling in love with this use of hands, not only brain, and I thought that is what I want to become in future. And since then, that's what I kept doing over and over again.
Perfect. So it's just a serendipity, I guess. Sometimes things happen before you recognize it. And then how do you decide to get into the clinical research and focus on the different things you've done, antiplatelets, access? How did you decide to do this work, and how were you able to get this done? It's a massive amount of work you've done.
So I think research was really within me because I started doing a lot of research even during when I was a student in medicine. I was doing research, of course, on various different topics. And I was really coming from the basic science, as I was telling you, because back then my chief were pushing me in that direction, which was not pleasing me very much. Then when I moved from internal medicine to cardiology, I started to more go into the translational phase, leveraging my knowledge about basic science towards clinics. And then after becoming an interventional cardiologist or after having hoped to become an interventional cardiologist, I perceived the importance of getting research answering very practical questions. So I immediately started to design and dream about studies which could address some of the open questions that interventional cardiology would face every day. And that's how my clinical research business has actually developed very easily from scratch. Nobody taught me how to do it. I had to do it by trial, by mistakes, by making errors, and with the help of many, including reviewers, editors, a lot of criticism, but of course always a lot of guidance coming through criticism. And step by step, the year after years, I learned how to do it, or perhaps I hope I have learned how to do it.
And Marco, you're one of the few people who combines excellent clinical skills with research. How do you balance that? How do you balance your work in the lab and doing these procedures with doing cutting edge research as well?
This is actually, I agree completely with you. I have had the privilege of working with a lot of interventional cardiologists, and really to pick up really the few of them who can really be top in both areas, it's extremely complicated. My recipe is very simple, and I learned this recipe from the Thorax Center in Rotterdam, where I trained myself, where I did my PhD. And the trick is very simple. You have to divide your cath lab days from your research days. As long as I can do this, I am successful in both. The days in which I'm forced to do both things at the same time, so I do a procedure, then I step in a teleconference, I step in a meeting speaking about research, going back to the cath lab. This combination of things is not really working out fine for my very limited mind. I need to have, how can I say, very clear boxes in my mind, very clear directories. One day is clinical activities, one day is research, and as long as I can do it, it's working out fine.
Perfect. So you separate your days, and one day you go full into one, and the other days full into the other discipline. So that's wonderful.
Correct. Also, because as you know, patients have their priorities. So as long if you are working in the cath lab, you will never be able to plan anything outside it in the 99% of the cases. That's why you need to do so to be respectful of both group of people, I would say.
Perfect. And then how did your training influence you? Obviously, Thorax Center is one of the places that trained a lot of outstanding people, in Europe and the world. How did that influence you, and did that have a big role in what you became?
Well, I think so. I think in terms of being fond of clinical research, I would name Patrick Serrayes, because I have to say he has been the most influential person research wise in my career. In the cath lab, as you know, there is nobody who can really do everything. There are a lot of different expertises, a lot of different ways of perhaps approaching the same problem, right? And so at the end of the day, you have to pick up something from everybody. And I was lucky enough to be in a very large center, such as the Thorax Center, where a lot of very good, talented interventional cardiology were passing by and teaching me a lot of things. And of course, on the other side, you have to be open to learn from all of them, because I think this is the trick. There is nothing perfect, nothing completely wrong. You have always to compromise, and compromising, learning step by step is more trick perhaps every day. I think that is what makes a very important, good interventional cardiologist, I would say.
Wonderful. And then, Marco, how do you prepare for your cases? Is there a specific routine you use, a specific sequence?
So I have to say it depends on the case. Of course, if you know what is coming next, it's already a luxury position, which in Europe we don't have much, because for economy, to be honest, for optimizing the workflow, we are doing a lot of procedure really online, meaning you do angiogram and then you have to get something done in terms of intervention. It's very rare that we can take the luxury of taking the patient off the table, discuss the case, how you would tackle it, and then go ahead and do it. Of course, there are some complicated procedures in which you have to do it. For example, CTOs or structure intervention. In those cases, you have to do it. But these are only 5 to 10% of my procedures. All the 90% has to be done online. And so you need to basically be prepared yourself to do even complex things without losing too much time. And so that's why I would say, as long as you can. Of course, it's an ideal scenario. You prepare yourself. Otherwise, you have to get it done immediately without having your mind getting into the complexity, but stepping into the complexity as it comes.
And then, do you get stressed out in the lab? Do you get, when things don't go well or there's an issue, do you get stressed? Do you get nervous? How does that work?
So in reality, the answer is yes. I am very a sensitive person. Of course, the older I get, the more I can control it, and the more I can, with I would say, with expertise, overcome my anxiety. But I am a person who can really be uh, perceiving the stress. But of course, I think starting from 20 years ago, where I started this job, and nowadays I can first hide it within the team. Nobody can perceive it, including the patient. And secondly, of course, even myself, I can coexist with that level of anxiety better and better, I have to say.
Wonderful. And then, do you get, if you have something go wrong, you have complications, something doesn't go well, do you get depressed? How do you deal with this? on a mental, psychological level?
So I am lucky because during the complicated case, I've always been able to have a bright mind, not to lose focus, but to get things pretty much in a straightforward manner. I have to say my anxiety during that moment even actually goes away because the complication has already occurred. So my anxiety is in expectation of the complication. But if and when the complication unfortunately comes, there is no anxiety anymore because the disaster is already in front of us. At that moment, I think that that part of my character is something which I have been very lucky about. I can really tackle it. Then after the case, it's a different story. Yes, I have to suffer normally some depression moments. Depression means that I really feel terrible for what I've done. I try to be as critical as possible, and I try, of course, to overcome emotions. And the only way I can do it by experience that I try to be as scientific as possible. What did not go well? What could have done to prevent it? And what could be done next to prevent the next complication, including the fact that I am trying to actually shape my research around complications. For example, the obsession about the radial approach really came because I had horrible femoral access complications during my early phase. Especially, I remember at the thorax center, I've seen so many because at the thorax center, the traditional approach was standard femoral access, more 7 than 6, even if it was not really needed. And then, of course, when I realized that everything could be done transradially, perhaps with a 5 French guiding catheter, in extreme cases, even a 6 French guiding catheter, that has actually triggered the idea and the design of matrix study. So I have to say, I am actually developing my research activity to try to give answers to complications and to my clinical duties, my clinical everyday practice. So I am trying to be researcher even more when I have complication because that is the perceived way I have to try to answer the complications back and try to avoid them as much as I can.
Absolutely, and you had tremendous impact. Matrix. I mean, there was many trials, but Matrix was one of the largest ones ever, and really, really provided people with the data needed to facilitate the switch, which is happening already in most places in the world. Now, when it comes to teaching, you've taught many people on research, clinical. What gets you excited in someone who wants to learn, in the student?
So I have to be honest, I am excited when I see someone who is trying to replicate the approach I had when I was a student myself, meaning not try to mitigate the effort, but try to get as deep as possible, try to have full understanding about everything. My typical approach to any topic was I had to read everything which is out there, making things extremely complicated to begin with, and only then simplify it. That's why if and when I see a student who is willing to devote time and commitment to whatever topic because of a genuine interest, that is really exciting me because I see a person who is building on his own and is investing on him herself. When I see students who are nowadays more and more frequent, who try to get the recipe done, already digested, that is not very exciting for me.
Wonderful. And so everyone is different, I guess, but you're right. Going to into the root of things makes things much more exciting. Now, what excites you the most right now? Again, you've been on the cutting edge on many different things. What are the things that excite you the most in 2025?
Well, the idea that I can still shape intervention and perhaps cardiology, not only with respect to my patients, but also with respect to the ways my friends and colleagues could practice that field across the world. Of course, as a doctor, the biggest dream is that all patients of yours are treated in the best possible way. But even more exciting is the next level of interaction, the fact that you are in a way not influencing, but helping your peers to do even a better job. And in a way that could end up in changing the guidelines, but as you know, that is part of one of the problem. The other problem is, of course, changing the guidelines, but having the guidelines implemented in practice. So it's a never-ending story from evidence generation to evidence implementation, and that is what really is exciting to me. Look, what I really like about interventional cardiology is that it's not never routine. It's always something new, and you cannot get how can I say, bored about what you're doing, because every single patient, every single procedure is different. If you attach to that level of diversity, complexity, also the fact that you need to generate research to have a full understanding on how research should be implemented, basically the word routine disappears, and that's what makes everything very much exciting to me.
Wonderful. And then, what do you do for yourself? Like, you have always endless energy and a lot of passion for what you do. What is the source of that? Were you born with this? Is that something you've been cultivating? How does that work out?
Uh, this is a difficult question for me. I would say first it's interest. The day I will be losing interest in generating new data, new evidence, that would be a difficult day for me, because then I will getting into the very boring moment of doing routine. And I would say what really is helping me a lot, that I'm trying to remain as active as possible, physically speaking. And I witnessed that throughout my career. I've always been very active in sports till 40. Then 40, for many reasons, I really gave up a bit in doing sports. And then I felt really tired. Now I'm getting beyond 50 and I'm getting more energetic than before, because I'm trying to run and do sports as much as I can. I was really very professional athlete in karate. I was playing karate really high level. And then when I get into the medical student, I had to adapt myself, because karate was a too physically demanding activity for me. As a medical student, was impossible. And then I started to do many other things. Now, unfortunately, the time is even more limited than before. So I'm jogging and running, but that I will never give up as much as I can.
Wonderful. Well, if I remember, you were planning for a marathon, so clearly you take it seriously, and you're pushing yourself. Very much.
My dream is to be a finisher, not more than this.
Now, how about any favorite books or any favorite movies you have?
So books, I have to say, in cardiology, as probably you would expect, I'm not reading many books anymore, but I was reading books during the early phase of my careers. And probably the most single influential book I read is the one coming from Eric J. Topol. I never had the privilege to work with the Professor Topol, at least in the cath lab, but I had the privilege to work with him at the level of research. I was a resident in cardiology when I was invited into a closed meeting during the European Society of Cardiology Congress in Munich. I was very young, and that meeting was held by Eric J. Topol, who for me was my hero back then. And I have to say, his books were remarkable for me, because they were already the combination of the clinicians I wanted to become. A person who was able to combine device and pharmacology into one specialty, which is interventional cardiology. So for me, the medical books, which in a way have most shaped my future and my thinking, are the one from Eric J. Topol. Outside medical books, I have a lot of Italian authors, of whom I'm very fond of. If I would name something, I would say the classical book I kept reading many times is The Count of Monte Cristo from a French author, which is Alexandre Dumas, and as well as perhaps Nick Hornaby, who wrote many books. The first book I have encountered is High Fidelity, and then through that book, all the others is very, how can I say, funny, light author who can really make me relax when I'm reading those books. I've been inconsistently reading non-medical books throughout my career, depends on the stage. I'm in a moment in which now I prefer to make one extra 10-kilometer run than reading a book. Perhaps in 5 years something will change. That will change.
Wonderful. And how about a movie? Is there any movie that you are particularly fond of?
So I think historically the Star Wars saga is probably the one I would name at the beginning, and secondly I should name Matrix, because it's where the movie that I used to develop my acronym of my first study, and now it's Matrix 2 is running, Matrix 3 is being planned. So this forward and visionary approach is what drives me, in the hope I could discover something which is perhaps already in front of us already, but I simply don't see it. And that's why I took the acronym out of me. And I like the idea. I like the idea, I have to say, more than the movie in itself.
Well, tell us a little bit about the upcoming studies. So, Matrix 2, Matrix 3. How do you get the ideas, and how do you think they will impact the clinical practice?
So Matrix 2 and Matrix 3 are pretty much a sort of connecting the dots of what I've been doing so far. I have been trying to simplify pharmacology as much as I could. That's all I have been doing so far, basically by step trying to reduce the APT as much as possible. And now I am working in a monotherapy concept. That is what Matrix 2 is about. Instead of having a short duration of 2 antithrombotic treatment in patient with atrial fibrillation, in the need of oral anticoagulation after stent implantation, we are trying to understand whether prioritizing a single type of monotherapy would make the job instead of combining them. If you look historically, we ended up prescribing triple therapy because we said we need to combine the best of two worlds, right? The prevention of stroke in atrial fibrillation patients, the prevention of stent thrombosis with the aspirin and a P2Y12 inhibitor, which ended up in 3 treatments, 3 antithrombotic drugs at the same time, and a huge amount of bleeding complications. The concept of Matrix 2 is after stent implantation, the highest risk is stent thrombosis. Therefore, stent thrombosis prevention should be prioritized. 30 days of P2Y12 inhibitor monotherapy, even in patients with AFib, without oral anticoagulation. And from day 31 onwards, only oral anticoagulation without any concomitant antiplatelet therapy, because at that moment, probably the risk of stent thrombosis is already so low that that would not justify the additional bleeding risk of having a second antithrombotic agent on board. And this study is already running with a lot of issues, but it's already running. Matrix 3 is basically trying to develop a no DAPT approach, basically only P2Y12 inhibitor monotherapy only, either ticagrelor or prasugrel in a randomized fashion, with and without aspirin in patients with ACS. This is going to be a very large study for which we are currently seeking funding. And I'm trying to do other stuff in the device space as well. Perhaps I would like to mention the use of stent retriever in patients with large thrombus burden. I think that is been a very successful story for our colleagues who are developing ways of treating a stroke. We could do the same actually in patients with large thrombus burden, because the stent retriever can actually be very safely and effectively used in the coronary vessel, pretty much as they are doing in the epicardial vessel. And I think that is probably something which will come in the future. This is again to show that I'm trying to combine always pharmacology and devices, not to go too much one way or the other, trying to be focused and balanced at the same time.
Yeah, perfect. And that's also, I love the crosstalk, as you say. It's the stent retriever specifically. We've used it a few times off label, and it's been actually fairly good. But I think the vast majority of cardiologists doesn't even know that they exist, and they're just used for the neurostroke operators. But in terms of the things that you do down the line, how many hours do they let you sleep every night?
So I'm trying to sleep, actually, if anything, because I'm running. And so even my Garmin watch tells me how many hours I should be sleeping. I would try not to go below 6 hours. That is the ideal scenario. Below 5 is still okay. Below 4, only if I'm on call. Otherwise, I will be in trouble the day after.
Okay. All right. So you maintain your energy despite the limited time. And then for the people who are listening, so what's a typical day for you? A typical clinical, a typical research day? How does this usually unfold?
So I would wake up at 5:30, 6 o'clock. I would try to do half an hour, 45 minutes of workout at home. I have no breakfast, so then I have a small espresso, and then I'm ready to go after a shower. I go in the clinic. We always start now with a meeting, a clinical meeting at 8 o'clock, where the entire department comes together. Half an hour of discussing cases, are in night cases, or we go through all admitted patients in the hospital. Then normally 8:30 I am in the lab until 6 o'clock if I am in the cath lab days, or I can do my research, meaning outside the cath lab, if I'm in a non-cath lab days. Research days does not mean 100% research. I would love them to be so. It's not the case. That includes outpatient clinic, a lot of administration, a lot of personnel meetings. But I am trying to be very respectful of cath lab versus non-cath lab, because as I was telling you before, I think cath labs requires such a bright and focused mind, which otherwise I would not be able to have otherwise.
Wonderful. Marco, what are the things that you are most proud of for the many, many things that you've achieved so far?
I would say perhaps I would say many. Probably the radial is one we already mentioned. I'm very proud of the fact that I'm in a way working to simplify the activity of our clinicians, of our friends and colleagues, is something which makes me proud. It's relatively easy to find money and support for investigating a new drug, a new device, a new agent, something which comes on top. It's extremely difficult to take something out. And that is my focus of my entire research. I am working on it. I'm pretty sure that soon I will be taking not completely out, but fairly out aspirin, for example, which I think is something which is probably relatively old and requires consideration before utilization, unlike what we do every day, which is the first drug we give in every single setting in which an antibiotic should be given. I would say also the fact that I was the first one randomizing patient with STEMI, receiving a drug-eluting stent. I remember back then I was a relatively youngest clinical researcher, and many would heavily criticized me because I was randomizing patient into studies, and I kept saying, as long as you are including patient to a study, even an apparently a risky or a stupid question needs to be answered. And now after 20 years I was right. Now drug-eluting stent is number one. Bare metal stent do not even exist. So probably in summary, something I'm proud of is to have developed a very clinically oriented yet research oriented mindset, to be able to treat patients really being informed by research and vice versa, and maintaining this balance. It has been extremely complicated. It is every day very complicated, but it's something I'm very proud of, and I wish I could really transmit and teach to many others after me, because my time is limited. 10 years I will be almost close to pension. Many others will have to continue this.
Wonderful. Now, in terms of going forward and the future, how do you see yourself in 5-10 years from now?
So I still have almost 15 years before I retire myself. I will try to consolidate what I've done so far. I would probably have time to do other big additional 5 RCTs. Meanwhile, I am more transitioning towards a leadership position within my hospital, trying to let the other people grow and take my role. I'm trying to push young generators to do research. I realize that I am a good cardiologist, I'm a good interventional cardiologist, but I have acquired an expertise and know-how on how to do research, which is really unique. So I hope I would be able to transmit that to many others after me. And I would love to be sitting at ACC, TCT, ESC, EuroPCR in the upcoming 5 to 10 years, watching my fellows who have become very well-known interventional cardiology presented the study I would have loved to. That would really be, I would say, the really cherry on the cake I would have loved to create.
Wonderful. And do you use AI at all? Is AI, you using it for research or clinical or other reasons so far?
So for research, yes, but I am terrified by using ChatGPT or similar AI tools for writing my papers, because I'm pretty sure once you start, it will be very difficult to stop. It's like a drug. You will get a sort of addiction towards it. So for being inspired, yes. For doing evidence search, yes. For summarizing the state of the art, yes, I'm doing it, but I never used AI to write a single line in my paper because I'm terrified by this as much as I would be terrified by drugs.
Wonderful. Again, lots of power, but as you said, there's still a lot of things to learn. And there was a study, the people who used a lot of large language models, actually their writing and verbal skills atrophied over time.
Yeah.
So I think you may be right on the mark over there.
Thank you very much.
So Marco, thanks for taking the time. If you had to give your top advice to young junior colleagues, as you mentioned before, who are planning to go follow your footsteps, do a career in interventional, clinical, and research, what would you advise them to do?
So to give yourself time, because something which I am very surprised about the younger and newer generation, that they don't want to give themselves time. They want to get everything done very quickly and very soon. Of course, that is for them a great asset because most likely they are much quicker than us, but they are very indulgent towards themselves. They don't give them the time and energy to learn new skills and new things. So, first, accept that you need time to develop yourself. That is the first one. And I would say probably stay humble, stay focused, because at the end of the day, consistency is much more important than the talent. The talent, either you grow up with this, either your father and mother gave you the good genes, or they do not. And at that moment, it's difficult for you to change. But the consistency and the perseverance is something that you can actually develop in your everyday. And that, I think, would make the difference between success and failure. And most importantly, they will bring you from failure to success, which is what matters the most at the end of the day.
Wonderful. So persistent, and things don't happen overnight. As you said, it takes many years to get things to mature, which is absolutely right. Marco, I cannot thank you enough. Phenomenal insights on how to build a career and how to learn and how to do good clinical and research work. Thank you so much, and look forward to your next presentation on one of the major meetings.
Thank you very much for having me. It was a pleasure speaking to you, Manos.
Thank you for listening to the Sensei podcast.